Okay, sir. So, sir, doubts also regarding MS. Yesterday itself, like people were giving us questions on the chat box, sir. So, Kaushik and Shruti has made a point to ask you those questions, whichever questions people have asked.
Okay, okay. So
I
let
don't
us,
think today anyone have given any new questions, sir. In that case, maybe can we continue with the thyroid presentation, sir?
okay. Oh, yesterday already they had asked about those questions that were there in the chat box, was it?
Yes, sir. Yes,
That
sir.
is very good. Actually, that can be done from now onwards because whoever is presenting, if you can have an access to the chat box, so you can definitely ask a question there in between, whatever that question is there, and we can clear the that particular doubt.
Sure,
That
sir.
okay.
Okay,
So
sir.
shall we start now?
Yes, sir.
Almost 19 students have joined. Okay,
Uh, Excuse me,
Krishna,
sir.
Hema, good evening to you both.
Good
So
evening, sir.
we will just I have your this thing in my mobile, whatever the history had presented. So one more thing yesterday I just wanted to add because whenever you take the history as far as thyroid is concerned, one is they usually complain of the swelling in front of the neck. So you have to discuss about the swelling in front of the neck, how it has developed, how the patient noticed, whether the patient himself noticed or herself noticed or somebody else noticed it and then told them. Because, if they have pain, usually they'll notice it earlier, isn't it? Otherwise, they may not notice at all. So whatever it may be, that you should always ask, who noticed the swelling? Just some minor inquiry from the patient and you can present it to the examiner. And the other thing is, as already you have discussed, how this thing has progressed, the swelling. So it is gradually progressed in size or a sudden increase in its size and associated with pain. Yesterday, we discussed about those things also. The other important thing is the pressure effects of the swelling because the swelling is in front of the neck and it can produce pressures over the trachea. It can also produce pressure over the esophagus and recurrent laryngeal nerve. So these are the three things which you have to discuss about. And yesterday we were discussing about the pressure effects. So the other important thing you will have to talk about is the signs, symptoms of hyperthyroidism and hypothyroidism. That is the next thing you will have to discuss. Other than these things, then only you will know whether the patient is hypothyroidism or hyperthyroidism or it's a simple goiter. So that way you can know. And the other important question which you have not asked and you should have asked will be like, this patient is having this problem for the past 3 months, isn't it? So what the patient did after noticing the swelling. So that becomes very important, whether the patient has gone to any doctor or not, whether any investigations has been done or not, any treatment has been started or not. So this becomes very important and what treatment, medication history patient is taking. And another important history is any drugs which can produce these kind of spills, goiters. So these are the important things. Plus, of course, the obstetric history, menstrual history becomes very important because these are also can give an indication whether the patient has any kind of abnormality of the thyroid functions, isn't it? So coming back to the pressure effects, which we were talking about. So one thing you said that the patient had complaint of difficulty to breathe in after lying down and after going to sleep, isn't it?
Excuse me, sir. Sorry to interrupt, sir.
Okay, okay.
Just wanted to ask Hema and Krishna, like, are you logged on to two devices because like there is an echoing happening?
Yeah, echo is there.
By any
No,
chance, did you log into two devices?
I am logged on one device.
Hema?
Yeah, I came out.
Okay, because like there was some echoing interruption in between.
Okay,
So,
okay.
okay, sir. Thank you,
Okay,
sir.
thank you, Mukhtar. So, Krishna, one thing is
Yes, sir.
there are other conditions also which can produce uh, difficulty to breathe in the night. So, like especially obstructive sleep apnea.
Yes, sir.
So if you just tell this particular symptom of the patient that the patient has difficulty to breathe in the night. Yesterday also we discussed why difficulty to breathe once the patient sleeps off the muscle tone will not be there, and the whole weight of the gland will be falling on the trachea and will be compressing. Let us say that the patient doesn't have this pressure effect because of the thyroid gland, but she also has an obstructive sleep apnea. Because, as you are trying to tell, your patient is probably a hypothyroid patient. Definitely, many of these hypothyroid patients may also suffer from obstructive sleep apnea, isn't it? They usually will have obesity, and obesity is definitely a sign of, or can induce obstructive sleep apnea in these patients. Now, Krishna, how do you differentiate between obstructive sleep apnea and because of the pressure effect of the gland itself?
Sir, with respect to obstructive sleep apnea, we can do the stop bank scoring as well. So that will give us a clear idea of whether the patient is having OSA or not. Stop bank, we will look for snoring. If we won't ask the patient, we can ask whoever's come with the patient, sir. So we can ask if they.
It is
Yes,
called as significant snoring.
Yes, sir.
It's just not snoring. Every one of us snores, but it has to be significant snoring. What is significant snoring? Just like that. What do you mean by significant snoring? You see, if that person with OSA is sleeping in one room, the room is closed, another person is sleeping in the next room, his sleep, the other person's sleep has to be disturbed by the snoring of this patient. That is called as significant snoring, because most of us have some amount of snoring will be there. That's the reason. Stop bang. So you have to ask the other person whether her sleep or his sleep is disturbed. And even if he is sleeping in the next room. Okay, what is T stands for?
T stands for tiredness during the day, sir.
Daytime tiredness and somnolence. Daytime somnolence.
O is any visible obstruction, sir. So again, we ask the patient's relative.
Not visible obstruction. Observation by anybody having this patient, struggling in the night with sleep apnea. That is observation of anybody. And P stands for pressure.
BM. P for pressure, sir. Yes, sir.
And then B stands for Bravo stands for
BMI, sir. So we look for a BMI of more than
30.
30, sir.
More than 30. And A stands for?
A stands for
more than 50.
A more than 50. Yes, sir.
N stands for?
N is the neck circumference more than 40 centimeters, sir.
More than 40 centimeters. Very good. Then G stands for?
G is the gender, sir. Male patients are more prone for OSA than female.
Isn't it? So that is another very important thing which you may have to differentiate. And because, even if the patient has OSA, then you have to be very careful before you induce the patient. Many of these OSA patients are extremely sensitive to sedatives. You have to be extremely careful in giving them the sedatives. And also in patients who have pressure effects because of the thyroid tumor itself. In both the patients, very careful, cautious in giving them the overnight sedation. And the second thing is, as we were discussing, a person has to be there to lift the thyroid gland away from the trachea, or you go for awake intubation. So even in OSA, it is always better to go for awake intubation. The other condition wherein these patients also can have the difficulty to breathe in the night is retrosternal goiter. Yes. That also you'll have to keep it in mind, because once you tell the patient has difficulty to breathe in supine posture, especially in the night, and has to change the posture, then these questions will be asked for you by the examiner. So a retrosternal goiter you have to rule out by examination or by investigations. So those things are there. Okay, so then again, other pressure effects, like we're talking about the recurrent laryngeal nerve palsy can occur because of the pressure over the recurrent laryngeal nerve, because the recurrent laryngeal nerve are very close. They are just, on either side of the trachea and esophagus. So they may get compressed, and then pressure effects may be there. And so if there is, hoarseness of voice, so what is the importance of that because of this pressure effect for you as anesthesiologist?
So if there is hoarseness of voice, then we will consider that there is a involvement of the recurrent laryngeal nerve already. So we can anticipate vocal cord palsy either unilateral or bilateral. So most likely it will be bilateral because unilateral may not produce a change in voice, sir.
No. Unilateral also can produce a change in voice. Initially, at least for first 3-4 months, till the the normal one crosses the midline and can meet. So it takes some time. So till then, these patients will have hoarseness of voice. So one important thing is we'll have to get a indirect laryngoscopy done, or at least a video laryngoscopy done before taking up these patients. That is one medical legal thing. The second thing is if you're planning for awake intubation, because let us say that it is a partial recurrent laryngeal nerve palsy. So if it is a partial recurrent laryngeal nerve palsy, usually the abductor fibers will be involved. We'll come to it later. And usually the vocal cord will be in the midline. If the vocal cord is in the midline, if you're planning for awake intubation, what is the problem for you? Awake intubation, because I said that you may have to go in for awake intubation also in these patients.
Sir, we may not be able to pass the scope, fiber optic scope at all if the is in the midline, and
No.
muscle relaxant to
One
give
thing
it
you
time.
should realize that both will not be in the midline. Usually, it can be only one-sided palsy. If both the partial paralysis occur, the patient will not be able to breathe. Both will be in the midline. Usually, if it is unilateral partial palsy, it can be in the midline. So the thing is, then you may have to take a smaller tube if you are planning to go for awake intubation. You can pass the fiber optic scope, no problem in passing the fiber optic scope, but you may have to take a smaller tube. So these are some of the things. And one more thing, the patients can have difficulty to breathe, and stridor can be there, even when the patient need not have to lie down or anything. Especially the lateral lobes are very large. They are compressing the trachea, and we know that scabbard trachea can occur. It becomes very narrow, isn't it? So that you will examine by using a Cocker's test. Then also the patients can have narrow trachea. Then also we will have to take care. So that we will discuss when we discuss Cocker's test. Okay. So these are some of the things. And now coming to the signs and symptoms of hypothyroidism and hyperthyroidism. Can you just, I think Hemavati can enumerate the
Yes, sir.
symptoms of hyperthyroidism and hypothyroidism?
Yes, sir. In hyperthyroidism patients, there will be weight loss will be there, sir, due to increased metabolic rate. Then increased muscle wasting will be there.
One thing is you should always tell weight loss in spite of increased appetite. That is the most important thing. Opposite in hypothyroidism. Whatever the symptoms are there in hyperthyroidism, the opposite symptoms will be there in hypothyroidism. So here, as you said, weight loss will be there, but instead of in spite of increased appetite, there will be increased appetite. They'll be eating like anything, but they'll be losing weight. So that is because of the increased metabolic rate they have. Whereas opposite in hypothyroidism, isn't it? So they'll have less appetite, but they'll be gaining weight. So that is one of the most important and probably the first symptom these patients can have. Okay, what are the other symptoms?
Then they'll be having hypothyroidism patient will be having heat intolerance, sir.
Heat intolerance and hypo? No, you just keep on telling both
Cold
together.
intolerance. In hypothyroidism, there will be cold intolerance. Weight gain will be there. Then in CNS, the hypothyroidism patient will be irritable, anxiety, tremors, and in CVS they will be having tachycardia, tachyarrhythmias. Palpitations are in symptoms. Palpitations. Yes. Then hypertension can also be there. Then in hypothyroidism patient, there will be bradycardia, hypotension.
Symptoms I'm asking. Symptoms of because we are still in the history, so you have to talk about the symptoms of hyper and hypo. So you can already you said that heat intolerance, whereas cold intolerance. That is another very important thing. And one common feature in both is easy fatigability will be there in both. Both will have easy fatigability. That is very common, will be there. And why easy fatigability in hyperthyroidism? Because there so much of energy is there, so much of increased metabolic rate, but still they may have increased amount of fatigue. They'll not be able to do their work properly.
Sir, because of the increased metabolic rate, there's an increased consumption of oxygen, sir. So oxygen requirement increases. So patient will become easily fatigued, sir.
No, but they'll be breathing also. There'll be increased respiratory rate, increase in tidal volume is very common in these patients, isn't it? But one thing is, in hyperthyroid patients, though the energy production is very high because of metabolic rate, the tissues will not be able to utilize this energy. That is the problem in hyperthyroidism. So that is the reason why they have, easy fatigability and, exercise intolerance is very common in them. Whereas in hypothyroidism, because the metabolic rate itself is very low. So that is the reason they have easy fatigability. Okay, palpitation is very common in hyperthyroidism. There may not be any serious thing in, important symptoms in hypothyroidism, but the thing is, both of these patients can go in for cardiac failure. In extreme situations, both hyperthyroid patients and hypothyroid patients. So what is the cause for cardiac failure in hyperthyroid patients and in hypothyroid patients? They will present to you with probably cardiac failure, extreme situations.
Sir, in hyperthyroid patients, because of the increase in heart rate and increase in oxygen consumption, there can be a left ventricular hypertrophy, sir, in the long run, and because of that can produce.
So one thing, Krishna, I want to ask you, because there will be what happens to the systemic vascular resistance in hyperthyroid. Hyperthyroid.
Hyperthyroid will increase, sir.
Hyperthyroidism. Systemic, there will be peripheral arteriolar dilatation, isn't it?
Yes, sir, dilatation. So it will reduce.
Dilatation is there. How do you think that there will be hypertrophy of the ventricle? It may not be. So usually there are two reasons why these hyperthyroid patients can go in for cardiac failure. One is that they may develop cardiomyopathy. Dilated cardiomyopathy can occur in hyperthyroid patients. Second thing is high output failure. Because, the heart may not be able to match the amount of increased metabolic rate. So that's how it goes for what is called as a high output failure. Whereas in hypothyroid patients, they go for congestive cardiac failure. That is low output failure. There's so much of myocardial depression, bradycardia. So that's why they go for low output failure. So this is one more difference you should be knowing about. So you have enumerated all the signs and you have discussed in your presentation. So including tremors, muscle tremors, and one very important thing which you have asked is the muscle weakness. That is a very important history you have to take in patients with thyroid disease, especially hyperthyroid patients. So Krishna, what is the importance of this muscle weakness in hyperthyroid patients? What kind of muscle weakness these patients can have?
Sir, with hyperthyroid, patients are more likely to be associated with myasthenia, sir. So at the end of the day, patient may have muscle weakness and.
But myasthenia gravis is okay, one of the things. But myasthenia gravis involves which group of muscles? Is proximal group of muscles or distal group of muscles?
Proximal, sir.
No. Myasthenia gravis always small muscles of the hand and also ocular muscles. The distal group of muscles are involved in myasthenia. But in these patients with thyroid problem, especially hyperthyroidism, the proximal muscle wasting will be there and also proximal muscle weakness will be there. That is very typical of hyperthyroidism and also many times in Graves' disease also. So suppose if it is there, why should you know about this particular thing? Suppose the patient has proximal muscle weakness, how it is important for you in managing the anesthesia management in these patients. It can be a myopathy, isn't it? They'll have a myopathy, proximal muscle weakness. Okay, Hema, how you think that this can affect your anesthetic management? Because I was telling you all these are leading questions only when you are taking history and whatever that is important for you in the management of anesthesia for these patients. And very important in the exam also, they'll ask you this. Proximal muscle weakness and wasting. The patient even may complain of wasting of the proximal muscles. So something is, okay, Hema.
During giving muscle relaxants like succinylcholine,
Yes, very good.
it will cause more twitching and contraction, and further fatigability of the muscle can occur.
No, you started right, but suddenly you deviated. What happens if you, in myopathy patients, succinylcholine is given? Any problems? Hyperkalemia is a problem, isn't it? In all myopathies, it's contraindicated. Succinylcholine is you don't give. It can produce hyperkalemia and sudden cardiac arrest can occur. So you don't use. So suppose the patient has either myasthenia gravis or even probably, this kind of proximal muscle weakness, myopathy of thyroid-induced myopathy, what we call it as. So you have to be extremely careful. It is better to avoid succinylcholine 1. The second thing is, if you give muscle relaxant, they may not come out of the muscle relaxants, or the muscle relaxants may have a prolonged duration of action. So you have to be extremely careful in using these muscle relaxants. And ideally, if you want to use a muscle relaxant, you have to use a neuromuscular junction monitor. And monitoring only, you will be giving, probably you should start with a smaller dose and then you can start increasing the dose. So that's how, and even repeat doses, you have to go with the neuromuscular junction monitoring. You have to give repeat doses. I still remember when I was in Ballari Medical College, we had one patient. He had muscle weakness, and then we had only pancuronium bromide was the muscle relaxant routinely used. We did not have atracurium and vecuronium long back. So after giving pancuronium regular dose of just 3 milligrams, so patient did not come out of the paralysis for 48 hours. It took almost 48 hours. After 48 hours, still then he was, put on mechanical ventilation and he was maintained. After 48 hours, he showed signs of, recovery, and then we could extubate him after 48 hours. So that is very important. This particular history, when you are taking when you are presenting in the exam, you stress upon this, that patient doesn't have muscle weakness or patient has proximal muscle weakness. So that, the next question will be by the examiner will be, why did you ask this? Isn't it? So that is very important. And of course, your patient has more of hypothyroid features rather than hyperthyroid features. But in the exam, whatever may be, whether your patient may have hypothyroid features or hyperthyroid features, any questions can be asked. It need not be pertaining to only hypothyroidism. It can be for hyper or hypothyroidism. So that you should always realize. Okay, another thing, Krishna, I was telling you because you presented, I told you, this patient had for the past 3 years the swelling in front of the neck. You have not told what she did after that.
Yes, sir.
That is very important. You have to bring it in the history.
Yes.
And did she show to any doctors? Was there any investigations done? And what the doctor told her? Have they started her on any treatment for for swelling? And why she has been admitted now? No, these things you should always bring in the history of presenting illness.
Yes,
Now,
sir.
just tell me if you have taken the history yourself.
Yes, sir. Actually, we had asked her if she had previously seen a doctor for it, and she said she was taking medications for the thyroid issue. And she said she was taking around 100 mg. She meant micrograms, but she said around that much she was taking, sir, on
Okay.
a basis, sir.
Now, how do you know if it says that she is taking some medications for thyroid problem?
Yes, sir.
How do you differentiate whether she is taking anti-thyroid drugs or thyroxine supplements by history? You have understood my question, isn't it? She
Yes,
can
sir.
take medication for hypothyroidism, that is thyroid supplements like levothyroxine.
Yes, sir.
If it is for hyperthyroidism, she will be on carbimazole or the methyl or propyl thiazole. Very rare, but carbimazole is the most commonly used drug. How do you
Yes, sir.
differentiate these by history? Because she may not tell you what drug she is on.
Sir, with thyroxine levothyroxine, she'll be taking on an OD basis, usually on an empty stomach, sir.
Very good, very good. So whereas in
Almost
anti-thyroid drugs,
so sorry, sir.
anti-thyroid drugs,
Anti-thyroid she usually take with meals, sir. Like not on an empty stomach,
taking
but with
2 to 3 times.
2-3 times.
Anti-thyroid drugs
Yes, sir.
are given usually 2 to 3 times a day because their half-life is short. Whereas, levothyroxine will be taking only once a day, that too early morning. She would have been specifically told, you take it early morning without taking any, coffee, tea or anything. Just as soon as you get up, you just swallow the tablet, isn't it? So a simple history, whether the patient is having hypothyroidism or hyperthyroidism. And this becomes very, very crucial for your history. So you finally come to a conclusion of whether it is hypothyroidism or suppose if you had told me this, that she's on levothyroxine once a day, early morning she is taking, and then, it would have added to your final diagnosis of hypothyroidism, isn't it? So that is why don't forget about this particular history.
Yes, sir.
Another very common thing in both hypothyroidism and hyperthyroidism, as far as obstetric history is, both diseases can produce infertility. So both hyperthyroidism and hypothyroidism, that can be common in both. So that is one more thing. And again, menstrual history becomes very, very important. So yes, of course, you have taken a menstrual history separately because again, in hyperthyroidism, what can be the changes in as far as the menstrual cycles are concerned?
Sir, in hyperthyroidism, it's more likely that she will have menorrhagia and dysmenorrhea, sir. Whereas in hypo, she'll have oligomenorrhea and amenorrhea.
Opposite. What you're telling is the opposite. In hyperthyroidism, oligomenorrhea, and even probably she may not have menstrual cycles at all. That also can be there. Amenorrhea can also be there. Whereas opposite in case of hypothyroidism, they have menorrhagia. And, polymenorrhea is also very common. And frequently they come to the doctor with severe anemias. And also because of the menorrhagia, they are posted for even hysterectomies. But if you correct their thyroid profile, they'll become all right. So that is another very common history. But you have taken that history, but you should always remember questions can be asked to you regarding these things. Okay. Yes. Then we will go into, so treatment history is very important. Medication history, yes, for MS patients also, I was telling, you should always ask what the patient has done, whether going to the doctor and what the doctor has told, what treatment the patient is receiving. And, this becomes very important. For example, if the patient may be on, let us say that the patient is a hyperthyroid patient, then the patient will be on antithyroid drugs, isn't it? So then we may ask you, what is the importance of the patient taking, carbimazole or propyl or methyl thyroxine? Can you just tell what is the importance of patient taking carbimazole or methyl or propyl thioamides? These are thioamides group of drugs. What is the anesthetic importance for these? Because I was telling you 3 things. Whenever a patient is on any drug, 3 things. One is if you want to do any investigation, one. Second thing is you want to continue the drug on the day of surgery. Third is what is the drug interaction between our anesthetic drugs and the drugs what we continue, isn't it? Usually hyperthyroid patients can be on mainly 2 drugs, isn't it? One is they can be on thioamides and beta blockers. Let us say the patient gives you history of hyperthyroidism and on thioamides. Like patient is on either carbimazole or methyl or propyl thyroxine. What is the anesthetic importance? Okay, Hema, you can answer.
We'll prescribe antithyroid medication on the day of surgery.
No. One thing is, I told you what any extra investigations you may have to do once the patient is on these antithyroid drugs. Any extra investigations you have to do. Can they produce any side
Yes, sir.
effects?
I will check for CBC, sir. There will be agranulocytosis, sir.
Yeah, they can produce. One is agranulocytosis. What is the other, toxicity they can produce? They can produce hepatotoxicity.
Yes, sir.
One is very serious agranulocytosis, another is hepatotoxicity. So you have to be extremely careful in these patients. You have to get liver function test and total count, differential count. Agranulocytosis will be very important. Next thing is I asked you, will you continue on the day of surgery or will you stop on the day of surgery?
We will continue on the day of surgery, sir.
Okay, you'll continue on the day of surgery because, you want their effect to be there during the procedure, isn't it? During the procedure, there can be a lot of release of these, hormones, and even there is always a probability of these patients going in for thyroid storm or thyroid crisis, so that you always continue. And from the next day, will you continue or you will stop?
We'll continue, sir.
No, from the next day, there is no point in continuing because their main effect is on the thyroid gland, isn't it? They interfere with the synthesis of thyroid hormones, and also they interfere with the release of thyroid hormones. So once the thyroid gland itself has been removed, what is the reason to continue these? There is no reason to continue, isn't it? You need not have to continue. The other things I was telling you is they can also be on beta blockers. Very commonly, the beta blockers are prescribed. So if the patient is on beta blockers, should we continue on the day of surgery or not?
Yes.
Beta blockers never be stopped. They have to be continued, definitely. So on the day of surgery. Next, should we continue beta blockers from the next day onwards, or should we stop like antithyroid drugs?
Can be continued if the patient is having any symptomatic tachycardia or something.
No. One thing again you should realize, these are the exam questions. That's why I was asking you. Because, circulating thyroxine levels will be very high in these hyperthyroid patients. So this thyroxine has got a 7-day life. Half-life of thyroxine, T4, is 7 days, whereas half-life of T3 is 1 to 2 days. Because these circulating the thyroid hormones will continue to be there. You stop the production by giving antithyroid drugs, definitely. And from next day onwards, there is no requirement of giving antithyroid drugs because there is no production, because the factory itself has been removed. That is a thyroid gland. But the circulating thyroxine hormones, thyroid hormones will be, again, can produce problems in the postoperative period. And, the problem of thyroid crisis or hyperthyroid crisis can occur even after 24 to 48 hours. That is because of the circulating thyroid hormones. So you have to suppress the peripheral effects of these thyroid hormones, and beta blockers are always given to suppress the peripheral effects of these thyroid hormones. So beta blockers have to be continued, but they are tapered gradually, because you should never withdraw the beta blockers suddenly, because the upregulation of the beta receptors, they can produce withdrawal problems. Sudden hypertension, tachycardia can occur. So you gradually, decrease or taper the dose by 7 days, and then after 7 days you can stop, because by that time the thyroid hormone levels also will have come back to normal. So that is another very important thing. So one more question you should always ask in the history is, is the patient taking any drugs which can produce goiter, which is called as goitrogens? Can you just tell me what are the drugs which can produce the thyroid problems and also a goiter?
Sir, drugs like syrup containing potassium iodide.
Yes, very good. Iodine containing compounds. Very good. Then
antiarrhythmic drugs like amiodarone.
Amiodarone. Very good. Very good. So amiodarone, what is 100 milligrams of amiodarone contains how much of iodine? What is the percentage of iodine in amiodarone? Again, there is an exam question for you.
8 grams.
It is 37 grams. 37% of amiodarone is iodine. This you should always know about. And what is the per day requirement of iodine? How much is per day, every day requirement of iodine to prevent a goiter? What is the requirement for all of us every day? Iodine requirement. A very basic question, isn't it? Basic physiology question.
5 grams.
No. It is 80 to 200 micrograms per day. Just imagine, just 80 to 200 micrograms of iodine is enough. But if a patient is taking 100 milligrams of amiodarone, he'll be consuming 37 grams of, 37 milligrams of iodine if he is taking 100 milligrams. So high iodine he'll be consuming, and this iodine, so much of iodine what he is taking can produce any kind of problems. It can produce hyperthyroidism or it can produce hypothyroidism. So that is why this is another important history you'll have to take, whether the patient is taking drugs like amiodarone, okay, or cough syrups like potassium iodide, expectorants. Yes, what are the other drugs which can produce goiters?
Anti-tubercular drugs like para-amino salicylic acid. Sir.
Very good. Para-amino salicylic acid, which we are not using nowadays. Right. Anything else?
Antipsychotic medications like lithium, sir.
Yeah, lithium carbonate. Again, that is another very important drug because lithium is a goitrogen. So you should always take this particular history also when you are presenting in the examination, because suppose if the patient is taking these drugs and he's developed this, so you just stop the drug. If you can stop the drug, the patient will become all right. The patient does not require any surgery or even any other treatment for his thyroid condition, because it is secondary to the patient taking a particular drug, isn't it? So that is why this history becomes important. Okay, so these are the histories you will have to take. And the other history, one more history is any exposure to any surgeries. You have written in the past history, the patient has not undergone any surgery. You think that this patient has not undergone a tubectomy? She has only 2 children, that too long back.
Yes, sir.
No, that is why don't forget about tubectomy.
Yes, sir.
Whatever the surgery, tubectomy is also maybe a minor procedure, she would have undergone. So you just mention it in the past history. Because, tubectomy, either it could have been done under spinal anesthesia, GA, or even local, isn't it? So at least you know whether there was any complications or it was uneventful. Any exposure to anesthetics becomes very important for us, or any untoward event that has occurred during that procedure. So that becomes important. So just ask about any anesthetic exposure or any surgery the patient has undergone. Okay, these are some of the things which now Krishna and Emma, I just want to ask you is, do you have any doubts regarding this particular discussion, what we have regarding the history? Because we'll go for examinations and management. Any doubts? Anybody has expressed any doubts regarding these things in your chat box?
Nothing as of now, sir.
Nothing as of now. Okay. Then Krishna, you present, you share the PPT and present the examination finding.
Okay, sir. Yes, sir. So on general examination, the patient is conscious, oriented, and comfortable on sitting position. Patient is moderately built and nourished, a height of 160 centimeters, weight of 60 kilograms. Patient's BMI is 23.4 kilogram per meter square. Patient has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema.
Next slide. Yeah.
So coming to her vitals, her heart rate was 75 beats per minute with a regular rhythm, normal volume and character, no radio or radiofemoral delay. Patient had a blood pressure of 120 by 80 millimeter mercury, measured in the right arm in sitting position. Respiratory rate was around 16 per minute, regular and thoracoabdominal. Saturation was 98% on room air, and her temperature was 38.4 degrees Celsius. So on airway examination, there was no gross facial deformity. Bilateral nasal passages were patent. Mouth opening was more than 3 fingers in mouth opening was more than 3 fingers. Mallampati grading 2, inter-incisor gap of 5 centimeters. Teeth were normal with no artificial dentures. Tongue is normal with no macroglossia or tremors. TMJ movement is normal and adequate. Sternomental distance is 13.5 centimeters. Thyromental distance could not be measured. Patient's spine was normal, and hands, she had no tremor in her hands. On inspection of the thyroid, on going to thyroid examination, on inspection of the thyroid, the patient is in a sitting position with her head thrust backwards. Apologize, sir, it was a typing error. Head thrust backwards against the hands clasped behind the occiput. A diffuse swelling in the anterior midline of the neck was seen, approximately 5 into 6 centimeters. Suprasternal notch is visible, and the lower border of the swelling is visible, approximately 2.5 centimeters above the suprasternal notch. So the swelling moves with deglutition, does not move with protrusion of the tongue. The skin over the swelling is normal, and no scars, ulcers, sinuses, or dilated veins were seen over the swelling, and no dilated veins over the neck or anterior chest wall. So on palpation, inspection findings were confirmed. Patient has no warmth or tenderness over the swelling. A swelling of size 5 to 6 centimeters was confirmed over the anterior midline of the neck, which has multiple nodularity and a bosselated surface, firm in consistency. The skin above the swelling is pinchable. The trachea is palpable and deviated to the left side. Kocher's test is negative. Carotid pulsation, bilateral carotid pulses are felt, so Berry's sign was negative. On percussion, a resonant note was heard over the manubrium sternum. On auscultation, there was no bruit heard over the swellings. So going to the other system examination, they proved with no significant features. Respiratory rate respiratory system showed a bilateral air entry was equal and normal vesicular breath sounds were heard, no added sounds. Cardiovascular system, first and second heart sounds were heard with no murmurs. On central nervous system, there was no focal neurological deficit. Patient's GCS was 15 by 15. Her motor and sensory examination was normal, and her detent reflexes were within normal range. And the abdomen was soft and non-tender. To summarize, a 45-year-old lady, a 45-year-old female homemaker from Vidippuram belonging to the lower socioeconomic status, presented with a swelling in front of the neck for the last 3 years of size 5 into 6 centimeters, moving with deglutition, with a history of difficulty in breathing on lying down for the last 2 weeks. This is a case of thyroid swelling, probable multinodular goiter with signs of tracheal compression without other compressive symptoms, with features suggest of hypothyroidism without any retrosternal extension, and patient is in sinus rhythm scheduled for total thyroid.
Okay, good. So you have done a detailed examination of the patient, but few of the things which I want to tell you is, first thing, when we were discussing about mitral stenosis also, I told how the patient, when you see the patient, immediately what observations you have made of the patient, whether she's comfortably sitting or lying down or anxious or apathetic looking. So those things becomes very important to differentiate between hyperthyroidism and hypothyroidism. So suppose if she has hyperthyroidism, how does she look like?
Hyperthyroidism, she can look thin, sir. She might have an emaciated look with an increased respiratory rate. Patient might also have a prominent exophthalmos. These kinds of symptoms could be, even the signs can be present, sir.
Most important thing, she will be a lot of nervousness, anxiety.
Yes, sir.
Fidgety, keep moving, and that thing will always be there. Whereas hypothyroid patients, how do they look like?
Usually lethargic, sir.
Lethargic, apathetic look. They are not bothered.
Yes.
Even if you are talking to them, they are not bothered about you, what you are talking about, or even they may not answer immediately. They may take a lot of time. So this one thing which you should always, first thing you should always talk about this. Patient looks nervous, agitated, isn't it? Or patient looks apathetic. And then you go with the other things like conscious oriented and all those things. So that's one thing, first thing. Second very important thing is regarding the skin and hair. You have to comment in thyroid patients in general physical exam.
Yes, sir.
What about the hair as far as these patients are concerned? Whether it is hypothyroidism or hyperthyroidism, how will be the hair changes?
Sir, in hypothyroidism patient, the scalp hair will be brittle, and sometimes alopecia will also be there, sir.
In hyperthyroidism, yes, very good. And very thin hair, and also there can be followed by alopecia. Whereas in case of hypothyroidism, there also, alopecia is very common, isn't it? Baldness is very common. Hair fall will be very much increased. And even the eyebrows, the lateral part of the eyebrows also may not have the hair. They may not have this also. So that is very typical of the hair changes as far as the hypo and hyperthyroidism is concerned. What about how the skin will be in hyperthyroidism? How the skin will be in hypothyroidism?
Sir, sweating will be present in hyperthyroidism patients. So
So
that is a dry.
moist skin in hyperthyroidism. Okay, moist. And then
dry skin in hypothyroidism patients.
Okay, what about when you touch the temperature of hypothyroid and hyperthyroid patients?
In hypothyroidism, warmth will also be there.
Warm and moist skin, you could have said,
warm,
isn't it? Whereas in hypothyroid,
it is cold and
Right.
clammy and
cold and dry skin, isn't it? So that is what very important is. You should mention in the general physical examination about the hair changes and also about the skin changes in both these. Because again, very important. I don't know what there was any hair changes in your patient because she has been treated with thyroid supplements. So once they get treatment, these hair changes may disappear also. So that is very important. And one more thing is, you have written regarding the nails. Will there be any changes in nail changes in hyperthyroidism?
plummus sign will be there.
Yeah, very good.
Where
What
there
is
will
this?
be
Very
separation
good.
of nail from the nail beds.
Yeah, what is this plumber sign?
Separation of nail from the nail beds.
Yeah, separation of the nail from nail bed, including there can be even clubbing can be there. That is in case of Graves' disease. Very common in Graves' disease. So that one again, you have to be ready to answer in the exam. You may be asked any changes in this thing. And one more thing is invariably they'll be asking about pretibial mixed edema because that is again a skin change in case of hyperthyroidism, isn't it? So what is this pretibial mixed edema in hyperthyroid patients? Okay, Krishna, you can attempt. Have you heard about pretibial mixed edema? That is not
Yes,
in hypothyroid patients. It will be there in hyperthyroid patients. What is this pretibial mixed edema? Okay, Hemavati.
So, it's a non-pitting edema over the
Very good.
anterior
Yeah.
of the tibia, sir, especially over the distal region, sir. And yes, sir.
It is a non-pitting edema, and
Yes,
also there can be nodules can be there, and extremely they can be itchy also. That will be there in case of hyperthyroidism, especially it is called as Graves' dermatopathy.
Okay, sir.
It is called as Graves' dermopathy or dermatopathy, and it is usually present over the front of the tibia and also lateral aspect of the leg. For the lateral aspect of the shin or front of the shin, it is very, very commonly present. It can be bilateral. So that will be there in, that's called as a pretibial mixed edema. And what is the cause for this pretibial mixed edema? Why these kind of skin changes will be there? It is because of the deposition of mucopolysaccharides.
Yes.
So in the
Okay.
subcutaneous region. So that is the reason. What about hypothyroid patients? They may also have non-pitting edema, but it can be all over the body, including the, isn't it?
Yes.
Face, tongue, everywhere there can be edema. And especially because of the edema of the face and, so the face is also enlarged, the tongue is enlarged in hypothyroid patients. So that becomes very important for us because it can produce a difficult airway for us.
Yes.
Isn't it? So this pretipial myxedema you should always talk about. So the other things about is the eye signs. Invariably, they'll be asking you about exophthalmos, even though
Yes,
the
sir.
patient may be a hypothyroid patient or patient may not have any eye signs or
Yes.
no exophthalmos, but invariably they'll be asking you about these things in the exam. So can you just mention at least 4 or 5 eye signs and how?
Stellwax,
Okay, Stellwax sign, right? Tell me.
Stellwax sign is staring look of the patient, sir. Patient will be having a staring look. Patient
Staring,
will be having staring look. Yes.
infrequent blinking. Stellwax sign is infrequent blinking with staring look. Okay, then.
And
Joffrey
Joffrey sign is where the patient wrinkle and no wrinkles will be present in the forehead, sir.
Now, when the patient is asked to look up with his eyes, there won't be any wrinkling of the forehead. That is called as a Joffrey sign. Okay, Von Graef's sign.
When the patient is asked to look down, there will be a lid lag will be present, sir.
So upper lid will not follow the eyeball.
Yes.
The eyeball will be coming, upper lid will lag behind. That is called as the Von Graef sign or lid lag test. Okay, Möbius sign.
Absence of convergence, sir. That is
very good. Absence of convergence. Okay, Dalrymple sign.
Dalrymple sign is where the upper part of the sclera will be visible, sir.
Yes, very good. So these 5 signs you just remember. There are so many signs, actually 20, 25 signs are there. Don't bother about all those. So, signs like Joffrey's, Von Graef's, and Dalrymple, and these some Möbius, Von Graef's sign, and these signs are more than sufficient. So 5 signs, if you just remember about that. One more thing, suppose if the patient has exophthalmos, there is something called as a mnemonic called as no specs. NOSPECS. That is for whatever the exophthalmos scoring system. NOSPECS scoring system. So do you know about this NOSPECS scoring system? Hemati, know about, have you heard about this? NOSPECS.
No.
What about Krishna?
No, sir.
Okay, so I'll just tell you, N stands for no signs or symptoms of exophthalmos. That is N. So you will be scoring 0 for that. Okay. Then O stands for only signs are there, no symptoms. Usually these people will have symptoms like, gritty eyes, continuous watering, the burning in the eyes, because they'll not be able to close it properly. Exposure will be there. They'll have a lot of chemosis. All those symptoms will be there. But need not have symptoms, only signs can be there. That is, only signs, but without any symptoms. And then SPECS, isn't it? S is soft tissue involvement, periorbital tissue involvement. If they have periorbital tissue involvement, swelling of the periorbital tissue also, that is S. P is proptosis, more than 20 millimeters of proptosis. So that can also be measured. The ophthalmologist will measure how much of the proptosis is there. So that also is more than 20 millimeters. If it is there, that you will be scoring 1 mark, again, 1 point. And E is extraocular muscle involvement. So many times, because of the proptosis and exophthalmos, so the movement of the extraocular muscles gets limited. And it can be in one eye, there can be more limitation rather than the other eye. This can produce diplopia for the patient. So this is E. E stands for extraocular muscle involvement. And then you have C, corneal involvement. Because what happens is, these patients sleep also. When they sleep also, they'll keep their eyes open. They cannot close the eyes. So that produces, exposure keratitis, and corneal involvement is there. So C stands for corneal involvement. And S is a very severe form of, the exophthalmos, that is sight loss. So blindness. Finally, it produces even blindness because so much of tissue, inflammatory tissue is deposited on the back of the eyeballs, can produce pressure effects on the nerve also. The optic nerve also can get degenerated. They'll have a sight loss. So this no specs is very important. So again, I'll repeat. N is no signs or symptoms. O is only signs, no symptoms. And S is soft tissue involvement. P is proptosis. E is extraocular involvement. And C is corneal involvement. S is sight loss. So just remember, you may be asked, because I still remember one of the examiner was very fond of asking about this no specs for the students. So that is one thing. And what is the cause for this, exophthalmos? This is also called as Graves' orbitopathy or ophthalmopathy. Both are called as this, either ophthalmopathy or orbitopathy. What is the cause for Graves' orbitopathy?
The thyroid stimulating hormone receptor has antibodies which will go and act on the retroorbital tissues, which has the receptors for antigen, and there will be an inflammatory process happening which will cause cytokines to get released, and then there will be fibroblasts will be forming there. So that will lead to
production of what there? Very good. Your answer is perfect, but what is produced there to push the eyeball forwards? Glycosaminoglycans.
Yes, sir. Glycosaminoglycans.
Yeah, the formation of glycosaminoglycans is the one which will start accumulating and then start pushing the eyeball forwards. So that will produce this. What is the patient also? Some patients can have proptosis. What is maybe the cause for proptosis, and how do you differentiate between these two? Not thyroid induced exophthalmos. Other patients also can have proptosis, isn't it? Protrusion of the eyeball is proptosis. That can be because of space occupying lesions behind the eyeball, especially intracranial tumors. They can start pushing the eyeball forward. That can produce a proptosis. Majority of the times it will be unilateral, whereas this will be bilateral. So that is one thing we should always remember about, to differentiate between exophthalmos and just proptosis because of intracranial problems. Okay. Now the other question you will be asked as far as the tumor is concerned. Now coming to, still we will just discuss about your vitals you have written. So the heart rate or the pulse rate, isn't it? You have written about 75. So how do you differentiate the hyper and hypothyroidism as far as the pulse rate is concerned?
Sir, with respect to pulse rate in a hyperthyroidism patient, if the patient is not on any medication, she is more likely to have a tachycardia, sir, even at resting state.
Very good.
And with the hypothyroidism, again, not controlled, she is likely to have a bradycardia or even bradycardia.
Okay.
And
so
with hypothyroidism, also likely to have arrhythmias like atrial fibrillation, sir.
Yes, very good. So that will be there in hyperthyroid patients. And one more thing, in the olden days, they used to go for sleeping pulse rate.
Yes, sir.
So we hardly do the sleeping pulse rate test nowadays, but invariably some of the examiners are fond of asking you how you do this sleeping pulse rate examination.
Sir, with respect to sleeping pulse rate, either if a normal patient, patient is sleeping normally, or if we can sedate the patient. If the patient is sleeping normally, we'll wait until 2-3 hours before the usual wake up time when they're in REM sleep, and then we will calculate the heart rate and palpate the pulse and calculate the heart rate, sir.
Patient will wake up.
Sir?
Patient will wake up if you hold her hand in the night.
Yes, sir.
So
we can do it by using a sedation, sir.
You have to sedate. That is what in the exam they want you to tell.
Okay, sir.
So you have to sedate the patient, and at least, you wait for 2 to 3 hours for sedation to be effective.
Yes, sir.
And afterwards only make sure that the patient is fully sleeping. Then only you examine the pulse rate, because if you just hold the pulse and suddenly patient wakes up, pulse rate will shoot up like anything. Even in normal persons also, pulse rate can go up. So
Yes,
based on the sleeping pulse rate, in olden days, they used to classify the hyperthyroidism. So how do you classify based on the pulse rate, the hyperthyroidism?
So the three gradings, grade 1, 2, and 3.
Okay.
Grade 1 is the sleeping pulse rate less than 90.
Mild,
Grade
moderate, severe.
mild, moderate, severe, sir. Mild is sleeping pulse rate less than 90 per minute, sir.
Okay.
Moderate is 90 to 110, and severe is more than 110, sir.
Yes, very good. So that is one thing you should always remember. Very commonly asked question in the exam. So you should be able to answer the sleeping pulse rate, how you check for the sleeping pulse rate. The other important thing about, you have written about the blood pressure is 120/80, isn't it? Will there be any change in the blood pressures in hyperthyroid patients and hypothyroid patients?
Again, sir, in hyperthyroid patients, if it's a long-standing hyperthyroid, patients can develop a high systolic blood pressure, and they can have a normal diastolic wide pulse pressure they can develop, sir.
They may not have normal diastolic. There will be, in the beginning only we discussed, there will be arteriolar dilatation, isn't it?
Yes,
So
sir.
that low diastolic pressure,
Low
high
diastolic.
systolic pressure.
Yes, sir.
Even they can have systolic hypertension.
Yes, sir.
So hyperthyroid patients can have systolic hypertension, also wide pulse pressure hypertension.
Yes.
That's
Okay.
very common because, they'll have increased amount of, the myocardial contractility, the stroke volume will be very high. That's the reason systolic pressure will be very high. They have very decreased peripheral vascular resistance. That is the reason why they have a decreased diastolic blood pressure. So wide pulse pressure is very common. Whereas in hypothyroid patients, how will be the pulse, blood pressure? I told you everything is opposite in case of hypothyroidism, isn't it?
Yes,
What
sir.
happens to the systolic contraction of the heart?
Will be reduced, sir.
Reduce. So what happens to the systolic
The
blood
pressure will also reduce, sir.
Now,
Accordingly.
what happens to the peripheral vascular resistance in case of hypothyroidism?
It will
So what happens to the diastolic blood pressure?
should
Increase. What happens to the pulse pressure?
it will narrow, sir.
Yeah, that is what you have to tell. So
Okay.
hyperthyroid patients are prone for systolic hypertension. Hypothyroid patients are prone for diastolic hypertension.
Okay, sir.
And wide pulse pressure in hyperthyroid patient, narrow pulse pressure in case of hypothyroid patients. So just remember about this. So when you are examining the blood pressure and when you present, the examiner may start asking about these particular questions. And again, coming to the examination of the swelling, one thing which you have not described is the extent of the swelling you have not described. So the lateral extension and vertical extension, you have to describe both in case of inspection. Once you describe in inspection, then you just say by palpation it is confirmed.
Okay,
Whatever
sir.
they. So vertical extension and horizontal extension.
Okay, sir.
From where to where the swelling is there, because it becomes again important for us regarding the pressure effects. It can be there, and even the extent of surgery, whether it the type of surgery. Suppose if it is only one side, it is there. It is not bilateral. So the surgery can be only hemithyroidectomy. It need not be total thyroidectomy or subtotal thyroidectomy. So that is why the extent of the swelling becomes important. So that you have not written. And one more question you may be asked is, because thyroid swelling is in the midline. So what are the other midline swellings just for differential diagnosis?
So other midline swellings, thyroglossal cyst is one, sir.
Thyroglossal cyst, okay.
Dermoid cyst is also another.
Dermoid cyst, right.
And
submental lymph nodes.
Submental lymph nodes, Ludwig's angina, sir, also.
And then submental lymph node, submental salivary gland enlargement. And as I said, thyroglossal cyst and thyroid swelling and subhyoid bursitis.
Subhyoid bursitis. Okay.
These are the few things. And whereas cystic hygroma can be there, but cystic hygroma will be usually on the lateral aspect. And branchial cyst also can be there, but usually on the lateral aspect. It will not be in the midline. So these are the swellings which are there in the midline. So this is very commonly asked question. And which are all the swellings among them will move with swallowing or deglutition? Among these.
Sir, thyroid swellings will obviously
Thyroid
move.
swelling is one. Okay.
Yes, sir. Thyroglossal cyst can sometimes also move
No,
with.
it will definitely. It will move both with swallowing and protrusion of the
And
tongue.
protrusion of tongue.
Okay, that is thyroclassal cyst. Any other? Pretracheal lymph nodes.
Pretracheal, yes.
Yeah, these three are the ones which move with the deglutition. Only thyroclassal cyst will also move with protrusion of the tongue. So why, thyroid swellings move with deglutition? That is another question will be asked. Because you will be looking for this, whether this particular swelling moves with deglutition, and you have written also in your examination findings that the swelling moves with deglutition. Why thyroid swellings move with deglutition?
Sir, thyroid gland.
Yeah, okay.
Go ahead.
Tell
The
Hemavati.
thyroid gland is enclosed by pretracheal fascia.
It is attached to pretracheal fascia. Very good. So what if it is attached to pretracheal fascia, why it should move?
Sir, pretracheal fascia is attached to the hyoid bone and thyroid cartilage, sir. And then ligament of Berry, suspensory ligament of Berry is also attached to the cricoid cartilage, sir. So while during deglutition, the fascia also moves and the gland will also be moving.
No, because one thing you should realize during deglutition, the whole of the larynx and trachea will be pulled up by the muscles. And because pretracheal fascia is attached to all these and also to the thyroid gland also moves up. And why the larynx has to move up? Because, while swallowing, it should not come in the way of food. So body tries to move it away from the, whatever the passage through which we will be swallowing. So that is what it moves up. The whole larynx will move up and the trachea also will move up. Now the pretracheal fascia is also attached to these laryngeal and tracheal structures. And pretracheal fascia also is attached to the thyroid gland. That is how thyroid gland also moves. So that is very, very important. That also one common examination question that you may be asked. And the other thing is about some of the signs of you have to, you have mentioned. One is the Kocher's test. So what is this Kocher's test? And I was telling you also, I will be discussing this about Kocher's test and its importance. How do you elicit this test?
Sir, so Kocher's test, what we can do is we'll be standing in front of the patient and we will compress both lobes towards the midline and we will listen to the patient for stridor, sir. If a stridor is present, it is a positive Kocher's test and it indicates a scabbard larynx, sir.
Scabbard trachea.
Trachea.
What do you mean by scabbard? What is the meaning of scabbard?
Scabbard is it's like a sheath, sir. It's almost a diamond-shaped Marion sheath, sir.
No, not diamond-shaped. It's a narrowed sheath.
Narrowed sheath.
They used to put knives or swords in that in the olden days.
Yes.
That is what is called as a scabbard. So, Hemavati, if a patient has this Kocher's test positive and you know that the patient is having narrow trachea, what is its anesthetic importance?
Sir, if Kocher's test is positive and stridor has been developed, it is suggestive of difficult airways, sir, first thing. And then we have
to take a smaller tube.
Yes, a smaller size tube, and then we have to pass the endotracheal tube bevel after the swelling, means below the swelling, beyond the swellings.
Yeah, that is what is very important if the Kocher's test is positive. And what is the the diameter of the trachea at which the patient develops stridor?
Less than 50%, sir.
4 millimeters. In adult patients, once it comes down to 4 millimeters, that is the critical diameter at which the patient can develop stridor. So if it is more than 4 millimeters, the patient may not develop any stridor. Okay, that is again one more common question that you will be asked. And the other test, to rule out the retrosternal extension of the goiter is Pemberton's sign. What is this Pemberton sign?
patient, we will be standing in front of the patient, sir, and then we'll instruct the patient to lift both the upper limb above the head, and then we will see for any flushing of the face is present or any dilatation of the veins is present.
Flushing or cyanosis?
Flushing, cyanosis.
They both cannot be there. Either it has to be
and
flushing.
dilatation of the veins is present.
There will be cyanosis.
Cyanosis, sir.
Because, what happens is, because the thoracic inlet is blocked now. The blood cannot enter. That is what, if the retrosternal goiter, it can compress on the superior vena cava on either side. So blood cannot enter. All the blood in the face, the venous blood will remain, and that can produce cyanosis. And also it can produce sudden increase in the intracranial pressures, and the patient will become distressed. So because it is quite dangerous, nowadays we don't do Pemberton sign, because it can sudden increase in the intracranial pressures can occur. So because we have lot of investigations, investigations are there. So you can go for a CT scan, or you can go for an X-ray chest. You will know whether there is a substernal extension is there or not. So you need not have to go Pemberton sign. So that is another thing. And one more sign you have written about Berry sign. So what is this Berry sign?
Sir, Berry sign is when in the presence of thyroid swelling, if we'll palpate for the carotid on both sides, sir. If the carotid pulse is present, then Berry sign is negative. When carotid pulse is absent, Berry sign is positive. This is because if the Berry sign is positive, it is because the thyroid is completely encapsulating the carotid artery, and we are unable to palpate it through the gland, sir.
So infiltration of the carotid sheath by the malignant thyroid.
Yes, sir.
It is a positive sign of malignancy. So you may not be able to palpate the carotid artery. So these are commonly asked one. And other things also, you may be asked, what are the different methods of examination of the thyroid? Can you just tell about 3 methods of examination of the thyroid? What is Lahey's method?
Sir, Lahey's method, you can go ahead, Liam.
Sir, we'll stand in front of the patient, sir, and then we will push the gland to one side, and then we'll be palpating the borders of the gland, sir, of the opposite side.
Okay. So pushing the gland to the opposite side and examining, so that you make the gland more prominent, isn't it? So
Yes, sir.
Both sides you have to do this.
Yes,
So that is Lahey's method. What is this Lahey? Is it a name of a person, or what is this Lahey? Lahey's method. It's a place in US, isn't it? So Lahey's medical center is there. Lahey's clinic is there. Lot of surgeries, thyroid surgery. It was very famous for thyroid surgeries. So majority of the thyroid patients used to be referred to Lahey's hospital. So they have started this particular type of examination. That is why it's called as Lahey's method. Okay. Then Pizzolo's method.
Pizzolo's method, we will ask the patient to clasp his hand and behind the occiput, and then extend the neck, and then we'll make the patient to deglutate, and then see
Make
for
the
any
gland
movement.
prominent, isn't it? You make the gland prominent by
we'll
asking
see
the patient to keep his hands over the occiput and then press over the occiput, so that he'll contract the neck muscles, so that the gland becomes more prominent. This is usually done in which kind of patients? Usually obese patients.
Patient with short neck, sir.
A short neck and obese patients where you may not be able to palpate the thyroid properly. Okay. Then Kreil's method, or Kreil Junior's method, Junior Kreil's method. That is, you will be examining.
We'll be using the thumb of our
thumb. You'll be, placing your thumb over the front of the neck and ask the patient to swallow, so that even small thyroids, you can, feel it, and then you can definitely examine. So that is what is Kreil's method. So these are some of the different methods of examination of the thyroid. So you will be asked about it. And definitely in a patient with hypothyroid patient, CVS becomes important. because bradycardia, and also there may be congestive cardiac failure. So you should look for that, because any patient with in failure, you cannot take up for any elective procedures. Even in hyperthyroid patients, they may develop, I was telling you, high output failure. So you have to look for the signs of high output failure. And that will be about CVS. Of course, in respiratory system also, there can be some changes can be there. So you can look after. Okay, look for these things. Anyway, finally, you will come to a diagnosis saying that, okay, either patient has got a goiter with hyperthyroid features or hypothyroid features, or well controlled or not well controlled. So that becomes very, very important when you are diagnosing. So here, hypothyroid patient, whether it has been well controlled or not controlled, well controlled hypothyroidism in this patient, because you have not written in the final diagnosis.
So
So it is well controlled,
yes.
because there are no features of as such, signs of hypothyroidism are not there. So well controlled hypothyroidism on levothyroxine 100 micrograms per day. So that if you had asked in the history, you would have told about. Okay, now this patient has been posted for, you said that thyroid surgery, isn't it? So what are the different thyroid surgeries these patients are posted for?
So depending on the size of the swelling and the extent, they can go for either total thyroidectomy or subtotal, near total thyroidectomy, or they can go for a
Partial thyroidectomy
partial thyroidectomy, yes, sir,
and hemithyroidectomy,
and hemithyroid.
isn't it? What is subtotal thyroidectomy?
Sir, the subtotal thyroidectomy, we leave, the surgeons will leave around 8 to 13 grams of viable thyroid left, so as to preserve a little bit of thyroid function as well as parathyroid, sir.
It's very good. So 5 to about 8 grams of thyroid are usually left behind. So that why this is important for a subtotal thyroidectomy compared to total thyroidectomy. Total thyroidectomy, full gland, everything is removed. They won't leave any thyroid tissue. So what is the complication that can occur with total thyroidectomy, which may not occur with subtotal thyroidectomy?
Hypothyroidism, sir, postoperative.
One is hypothyroidism. Second, parathyroids are also removed in total thyroidectomy.
Hypocalcemia.
Hypocalcemia. So, later they can develop hypothyroidism and hypocalcemia if total thyroidectomy is done. Unlike in subtotal thyroidectomy, this is definitely prevented. So that is the difference. And again, total thyroidectomy with radical neck dissection also can be done in malignant thyroid tumors. What is hemithyroidectomy?
So hemithyroidectomy, they will remove one lobe entirely in addition with the isthmus, sir.
Isthmus. That is hemithyroidectomy. What is partial thyroidectomy? Usually, sometimes what happens is only the isthmus gets enlarged. The lobes are not enlarged at all. So for a cosmetic purposes, that is removed. The isthmus is removed. That is called as partial thyroidectomy. So just remember about these. Sometimes you may be asked what are the different surgeries that is being done. Okay. Now, what are the different types of treatment for hyperthyroidism usually done?
Sir, medical management, we can go for
medical management.
One is medical management, sir. We can also go for Lugol's iodine, sir. And
medical management is different. That is already we discussed. Usually thioamides, the patients will be on carbimazole and or methylene propyl thiouracil. Okay.
Obviously, surgery.
Surgery is another one. The third is
and radioablative.
Radioactive iodine therapy. So these three things they can have. So, for example, if the patient is having hyperthyroidism, Graves' disease, can be managed with only medical therapy also, isn't it? So what are the advantages and disadvantages of only medical therapy?
Sir, we can avoid surgery and avoid the general anesthesia altogether with this kind of patients. Therefore,
avoid the risk of surgery. Risk of surgery.
And avoid the risk of dealing with a difficult airway, sir. That is one.
So, but the disadvantages?
Disadvantages, if the patient is presenting with pressure symptoms, they will continue. And cosmetic reasons also, patient may not be comfortable with thyroid swelling if it is present. So.
Advantages are delayed hypothyroidism and
Yes,
also side effects of the drugs.
yes.
That is always there. How about radioactive iodine therapy?
So radioactive iodine therapy, it will also cause complete destruction of
What are the
the
indications for radioactive iodine therapy?
Malignancy changes.
No, malignancy you don't give, isn't it? No, what are the indications for radioactive iodine therapy in hyperthyroid patients?
So indications, one is if we want to bring the patient to euthyroid state before surgery, sir. That is one.
Not for, if the patient is, you are going in for, thyroid surgery, you will never give the radioactive iodine. So it is always direct surgery. So radioactive iodine usually in young patients with minimal thyroid enlargement, especially Graves' disease where there is hardly a diffuse enlargement will be there. In such patients, radioactive iodine therapy is now, here also you can avoid surgery, isn't it? Risk of surgery you can definitely avoid. Risk of complications of surgery like recurrent laryngeal palsies and all those things you can avoid. So radioactive iodine therapy, usually many times even single dose of radioactive iodine 131 is used. Sometimes you may be asked in the exam. So radioactive iodine 131 is used for radioactive iodine therapy. So how it is given, radioactive iodine therapy? Parenterally, orally, what?
The radioactive iodine pellet is usually
It is given orally.
Pellet is into the thyroid gland and it is
No. It is given to swallow. Radioactive. That is such a simple therapy. That's why in many of the Western countries nowadays they are going in for radioactive iodine therapy for Graves' disease and diffuse goiter, not much of a cosmetic problem. So that is why they are going in for that. Only problem with radioactive iodine therapy is that you cannot use it in older individuals because in older people it can induce malignancy as Hema was talking about. And second thing is it produces total destruction of the thyroid tissue. So invariably the patients will have hypothyroidism for life. So they have to take, isn't it? So the third option is of course surgery. So this patient has been posted for surgery. Surgery is usually used in many of the patients where there is gross enlargement of the thyroid. Whenever there is a multinodular goiter is there, when, as you said, when pressure symptoms are also there, and when medical therapy has failed to produce complete relief of the toxicity of thyroid. So these are some of the indications for surgery. So, okay, if the patient is now posted for surgery, now, what are the investigations you'll be doing and how do you prepare this patient and how do you manage the anesthesia for thyroid surgeries?
Sir, preoperatively, I'll first give the pre-medicate the patient with
No. First, you have to investigate the patient. Then you have to prepare the patient.
First, I'll go ahead with
So first talk about the investigations and each investigations, why you want to do, what is its significance, and then you go for how do you prepare these patients before surgery, and then anesthesia technique for these patients.
Sir, I will ask for CBC in view of to rule out any anemia and any thrombocytopenia, any granulocytosis if the patient is on any anti-thyroid medications.
No, one is you said hemoglobin, isn't it? That is very important. Why do you want to get a hemoglobin done in these patients? What is the importance of getting a hemoglobin done?
So we can rule out presence of an anemia, sir.
Especially is anemia common in this
patient? Sir, especially if she's a female patient, she's more likely to develop anemia, sir.
No, how about in hyper and hypothyroid patients? Is anemia common?
No, sir.
In both, anemia is very common. In
Okay.
hyperthyroid patient, because so much
Baseline.
increased metabolic rate, whatever, how much they eat, it will not be sufficient. So there will be a nutritional deficiency. So they do develop anemia. In hypothyroid patient, they hardly eat. They'll have multiple nutritional deficiencies. So anemia is very common, and anemia is very common in hypothyroidism. And why should you get a hemoglobin done? Suppose just to know the anemia is there or not. What is the importance? They are being posted for surgery. What is one common complication of thyroid surgery?
Bleeding.
Bleeding. Bleeding is the most common complication, isn't it? Especially if it is a large thyroid. Large thyroid, usually the bleeding. What is the normal blood supply to the thyroid tissue? How much blood supply? Normal thyroid weighs how much? What is the weight of the normal thyroid?
80 to 100 grams, sir.
No. It's a goiter. If it is 80 to 100, it will be a goiter. What is the normal weight of the thyroid? It is 15 to 20 grams. These are all exam questions again. Whatever I am asking is all, I would have asked many students as an examiner, isn't it? So you should know about this. And what is the amount of blood supply to this thyroid? How much?
100.
It is about 4 to 6 ml per gram per minute. 4 to 6 ml per gram per minute. It comes down to 100 ml, as you said, per minute. That is the amount of blood supply to the thyroid. But what happens in hyperthyroidism? How much increase of blood supply will occur? It increases by 10 to 20 times. That means it can be 1 to 2 liters per minute in extremely very big thyroids with hyperthyroidism. So that is why when they do surgery, there can be a lot of bleeding, isn't it? So unless you know that what is the hemoglobin, you know that what is the requirement of the blood to be arranged, how much packed cells you have to arrange. That is based on maximum allowable blood loss. You go with MABL and then you will be arranging, isn't it? So that is why hemoglobin becomes very, very important investigation. And we were just discussing about the blood supply. What are the different arteries which supply this thyroid?
Superior thyroid artery.
Very good.
Inferior thyroid artery from the carotids, directly from the supplying from the carotid.
Superior thyroid artery is from external carotid artery. So inferior thyroid artery is a branch of thyrocervical trunk of subclavian artery. So they'll be asking about a brief anatomy of the thyroid gland. So that is very, very important because thyroid has got two glands and thyroid means shield. So it is the shape of a shield. They used to wear armor. So it looks like that. And it is present just below the cricoid cartilage. Though it is called as thyroid, it is not present in front of the thyroid cartilage. It is below the isthmus is present below the cricoid cartilage. So two glands on either side attached by the isthmus. So that is a brief anatomy, and plus, the blood supply they'll be asking you, and the nerve supply also they'll ask. What is the nerve supply of the thyroid?
Recurrent laryngeal nerve and superior laryngeal nerves.
Yeah, recurrent laryngeal nerve and the superior laryngeal nerves are the ones which supply. That becomes very, very important. Later, we'll have to talk about that. Okay, coming back to the investigations. So hemoglobin and of course leukocyte count, because agranulocytosis is very common as a side effect of these thioamides, that you have to get it done. Okay, what are the other investigations?
Then I will go ahead with serum electrolytes, sir. Then
okay, why serum electrolytes? Just for the sake of doing it or any particular reason? No, just for the sake of doing investigations, you should not do, isn't it?
Sir, we would want to know a baseline calcium, and we also want to know if the patient is having any sodium deficiency, sir.
Now, in which condition hyponatremia can occur?
Hypothyroid, sir.
Hypothyroidism. They can have hyponatremia, and hypocalcemia can be there in hyperthyroidism and hypothyroidism.
Yes, sir.
Why calcium deficiency will be there in, you mentioned it, I'm asking you, why calcium deficiency can be there in hyperthyroid patients?
Sir, it will be an increase in calcitonin, sir, and maybe that will produce decrease in serum calcium.
Now, because what happens in case of hyperthyroid patients, there is, lot of what is called as hungry bone syndrome. So usually the calcium levels may be normal or maybe on the lower side. And once you treat these patients or remove the gland, so suddenly there will be a lot of resorption of calcium from the blood into the bones. And that can produce severe hypocalcemia once surgery is done. So that can be one of the causes for hypocalcemia in these patients. As you said that the calcitonin also may be a problem, but usually that may not be a problem much unless there is a medullary carcinoma of the thyroid, which is usually because of the C cells, isn't
Yes.
it? And hypothyroidism, definitely because of the nutritional problem, they can have the hypocalcemia, but hyponatremia is very common in hypothyroid patients. So that for that, okay, electrolyte studies you will be doing, right? What are the other investigations?
Then I'll go ahead with serum triglycerides and cholesterol levels, sir.
Okay, that is more common. You have to do get it done in hypothyroid patients.
Serum triglycerides and cholesterol.
In hypothyroid patients, lipid profile.
Yes, sir.
Okay.
It will be elevated, so I will go ahead and investigate.
Okay.
That.
Okay.
And then LFT, baseline values of LFT.
Okay, again, because these patients, hyperthyroid patients on thioamides, liver functions, you have to get it done because hepatotoxicity can be there, right? Okay. Then
I will go ahead with RFT in patients with more than 40 years of age.
Renal function test, right?
Then normal ECG, baseline ECG, chest X-ray, sir.
And what are the ECG changes in hypothyroidism and hyperthyroidism?
Sir, sinus bradycardia can be present in hypothyroid patients, and in hypothyroid patients there can be sinus tachy, and any AF conditions can also be there. Tachyarrhythmias.
Okay. What else? What happens to the voltage of R waves in both the conditions?
It will be a low voltage complex. So
low voltage complexes in which condition?
In hypo, sir.
Why low voltage complexes? Because depressed myocardium.
Yes, sir.
Hypothyroidism, isn't it? There is a depressed myocardium. Myocardial contractility is very minimal in hypothyroidism. It is not very effective. That is why, their cardiac output will be on the lower side. Whereas in hyperthyroidism, what happens to the amplitude of the R waves?
It will be increased.
Yeah,
Again,
tall
increased contractility, increased heart rate.
Tachycardia with tall R waves in hyperthyroidism and bradycardia with low
voltage complex.
Low voltage complexes in case of hypothyroidism. So plus atrial fibrillation is one of the common type of dysrhythmias that can be there in hyperthyroidism. That also can be there. Okay. Then other investigations. Yes.
Sir, other investigation, baseline thyroid TFT values, thyroid profile values.
Okay. Now coming to specific investigations. You can always tell generalized investigation and specific investigations whenever you present in the exam. Whatever you just now told, all those are generalized investigations. Whereas specific investigations now for this patient is thyroid function test, isn't it? So when you talk about thyroid function test, invariably you'll be asked about how these the synthesis of thyroid hormones. That is commonly asked. Can you just talk about the different steps of synthesis of thyroid hormones?
Yes, sir. So the first step is iodide trapping, sir.
Now, before
So
that, first step is actually iodine has to be absorbed from the gastrointestinal tract, isn't it?
yes, sir. So iodine is absorbed from the intestinal tract.
Iodine in the food is absorbed by the gastrointestinal tract. And what happens to this iodine in the gastrointestinal tract?
It will be converted into iodine.
Yeah,
It will be
it is
converted to
reduced,
iodide.
yeah, it is reduced to iodide.
Iodide.
Iodine is reduced to iodide because that iodide only can, travel in the blood.
Yes, sir.
Direct iodine cannot go through in the blood. So now iodide will start flowing through the blood towards the thyroid gland. So what happens here?
So then in the thyroid gland, it gets trapped into the follicular cells, sir.
Okay, what do you mean by this? What do you mean
sir,
by iodine trapping?
Sir, it goes via the sodium iodide synport pump and enters the follicular cells, sir.
No, what do you mean by iodide trapping? Hema, you can just tell about what is iodide trapping.
Sir, from the circulation, it enters the follicular cells and then enters the colloid.
No.
And then
No, it is there. But what do you mean by trapping? It is trapped by the thyroid gland, isn't it? So what do you mean by trap? Trapping means, normally, these whatever drugs may be there, or even these electrolytes, or even iodine, whatever it may be, all these things in the body, it will go with the concentration gradient from a higher concentration to a lower concentration. But here it is opposite. So actually there will be a high concentrated iodine is already there in the thyroid gland normally. So against a concentration gradient, this iodine is trapped, this iodide is trapped by the follicles of the thyroid gland. So that is why, because of the against concentration gradient, iodide enters into the thyroid gland, it is called as iodine trapping. That you should always remember. What is the ratio of iodide in the blood and in the gland? Because I was telling you against concentration gradient. Now, what is the concentration gradient between the blood and then the thyroid gland? It is 1:5. So if it is 1 part in the blood, 5 parts will be there in the gland. So against a concentration gradient, the iodide is moving into the thyroid gland. That is why it is called as iodide trapping. Okay. In hyperthyroidism, what is the ratio? What is the concentration gradient?
It would be reversed, sir.
Not reverse. There will be so much of iodide in the thyroid gland. So much of manufacturing of thyroid hormones are occurring in
10
hyperthyroid.
times more. 10 times more.
In hyper, sir.
Hyper.
Hyper, it will be increased, so there will be a greater concentration.
What is the ratio that is there in the books? Invariably you will be asked again. It is 1:20. The iodide is trapped, though there is 20 times more iodide in the thyroid gland. Even then, it is trapped by the follicles of the thyroid gland. So that is called as iodide trapping. So which particular hormone, potentiates this iodide trapping? Again, TSH.
TSH, yes, sir.
TSH. Everything is by the TSH except oxidation of the iodide to iodine, that is by peroxidase and organification. The oxidation and organification is by peroxidase. Yes. But all other things, all other steps are by TSH, thyroid stimulating hormone. Okay, now iodide trapping has occurred. Now next step.
Next is will be followed by oxidation, sir. Whether iodide is oxidized to iodine because of thyroid peroxidase.
Okay, very good. Then
this iodine will react with tyrosine to form monoiodine tyrosine and diiodotyrosine, sir.
Where will be this tyrosine?
So it will be present within the follicle cells, sir.
As what? It will be there in the, not in the cells. It is there in between, in the middle of the follicles as a colloid, thyroglobulin.
Yes, sir.
There in the colloid tissue, that is a thyroglobulin, and thyroglobulin contains tyrosine, and this tyrosine will combine with iodine, and form
monoiodine tyrosine and diiodotyrosine, sir.
Yes, very good. So
IT
this
and
is,
DIT.
this is called as organification of
Yes.
iodine. Then next
Yes.
step.
Following this, there will be combining of MIT and DIT. MIT and DIT will combine to form T3, sir.
Okay.
And MIT and two molecules of DIT will combine to form T4, so thyroxine, sir.
Okay, okay. So what is the full form of thyroxine, T4 and T3?
So triiodothyronine and
Yes,
tetraiodothyronine.
so tetraiodothyronine and triiodothyronine, because tetraiodothyronine, 4 molecules of iodine will be there in thyroxine, T4, and 3 molecules of iodine will be there in case of T3. So that is again, in a benzene ring, you have 3,5,3,5 tetraiodothyronine. It is called as third position, fifth position on one benzene ring. Again, third position and fifth position in another benzene ring. 3,5,3,5 tetraiodothyronine. Whereas triiodothyronine is 3,5,3. 3,5,3. So in one benzene ring, it is third position and fifth position. In another benzene ring, it is third position, 3,5,3.
Okay, sir.
Because, deiodination of the T4, you get T3.
T3.
Isn't it? Peripherally, that is what occurs. Isn't it? So now you have T4 and T3 are formed in the, the thyroid follicles, and they are stored there.
Yes, sir.
What is the next step? Storage and release. So
And release.
Released.
So it is released by cleaving from thyroglobulin molecules, sir, via proteolysis, sir.
Yes.
So through proteolysis, it is cleaved from thyroglobulin and it is released into the circulation.
From the cells. Actually, it gets stored in the cells also. Now,
Yes.
from the cells, it gets released by pinocytosis, cleaving of the cells. So, and once it enters the blood, it will not be in the free form, isn't it? It immediately gets combined, most of it, by what are the proteins that combine with this thyroid hormones?
Thyroglobulin.
TBG, thyroid binding globulin, then prealbumin and albumin.
Prealbumin.
Are the 3 proteins which combine the thyroid hormones. Thyroid binding globulin, almost about 80 to 85%, it is bound by TBG, thyroid binding globulin, about 5 to 10% by prealbumin, and again about 5 to 10% by albumin. So that's how free form will be very, very minimal. And from the gland, 80% or 85% of the hormones that are released from the gland are T4, thyroxine, and about 15 to 20% are T3. And majority of the T3 that is there in the circulation is again by conversion of T4 to T3. Almost 80% of the T3 that is in circulation is by deiodination of T4 into T3. That you'll always remember about. And what is the percentage of T4 that is bound to the proteins? How much of the T4 will be bound to the proteins?
So only 0.1% will be free hormones, sir. The rest is bound, sir.
0.2%.
0.2%.
99.8% of the drug of T4 will be bound to the proteins, and only 0.2% will be free. And how about T3? It is 0.3% will be there. 99.97% will be bound to the proteins. So only 0.3% will be in the circulation as free form. Because why it's important to know is because we'll also be measuring free T4 and free T3, isn't it? So invariably, they'll be asking you about the different steps of thyroid or thyroxine synthesis or thyroid hormone synthesis. That is very important. Now coming to the specific investigations. So what are the hormonal studies? What are the things we'll be doing?
Hormone, yes, sir. Then I'll ask for thyroid function test or free T3, free T4, and TSH, and total T3 and total T4.
Okay, can you just name the or tell the values?
Yes, sir. For
T4.
free T,
Always tell about total T4, total T3, then TSH, then free T4, and free T3.
free T3 is 2 to
So
4
first,
point.
now you start from total T4, total T3.
Yes,
That's
sir.
how you get also.
Total T4 is 5 to 12 micrograms per deciliter, sir.
It's very good.
And then total T3. Total T3 is around 100 to 195 micrograms per deciliter.
No.
It is 70 to 195 micrograms per deciliter.
Not micrograms. That is why, it is important.
Nanograms
per deciliter. Okay. Yes. Then, because you have written some of the investigations, but you have not written the measuring units. Very important measuring units for the exam. Okay.
TSH is around 2 to 4.5 picograms per
TSH.
No, sir. She was saying free T3, sir. Free T3 is
0.5 to 5.
I said total T4, total T3, then TSH, then free T3, free T4. Like that only you have to talk about in the exam. So what about the TSH, which is the most important investigation?
0.5 to 5 micro international units
per ml. Very good. Or milli international units per liter. It can be expressed either way. Micro international units per ml or milli international units per liter. Okay. Now coming to T4, free T4.
Free T4 is around 0.9 to 2 nanogram per deciliter.
Per deciliter. 0.7 to 2 nanograms per deciliter. Very good. So then free T3?
0.7 to 2.5
picograms. They are not nanograms. Free T3 is picograms per deciliter. So these things you should always remember. It is always better to write down when in your case sheet itself. All these, the measuring units also, with the measuring units, you should write down, because you will be having a lot of confusion when you are telling in front of the examiner. These nanograms, picograms, micrograms, micro international units, milli international units. So all those things are there, isn't it? So what are the other investigations also you can do? But before that, now what is the relevance of these? What about TSH? Suppose the TSH is on the lower side. Let us say it is less than 0.5. What does it indicate?
It's indicating hyperthyroidism.
Let us say it is 0.5, below 0.5. It is 0.2 or 0.1, but T3 and T4 are normal.
Subclinical hyperparathyroidism.
Hyperthyroidism, not parathyroidism.
Hyperthyroidism.
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 Subclinical. But if it is below 0.03 and with T4 and T3 are raised, then it is overt hyperthyroidism. Okay. What about, how do you classify hypothyroidism based on TSH values?
Primary hypothyroidism and secondary hypothyroidism, sir. Where primary hypothyroidism, the TSH values will be high, and TSH values will be high, and T4 and T3 will be low.
Okay. In secondary hypothyroidism?
In secondary hypothyroidism, the TSH value will be low, and T4, T3 will also be low. Sir. Everything will be low.
What is the cause for secondary hypothyroidism?
Secondary hypothyroidism, sir. Any pituitary or hypothalamic tumors, sir?
Destruction of the either hypothalamus or pituitary. From the anterior pituitary, you have TSH, isn't
Yes.
it? From the hypothalamus, you have TRH,
Yeah.
thyrotropin releasing hormone. So, thyrotropin releasing hormone will release TSH. And in turn, TSH will be acting on the receptors on the follicles, and then it will help in all the many of the steps of thyroid synthesis, isn't it? That's how. One negative feedback is also there. If there are increased circulating thyroid hormones, TSH will not be secreted much. TSH automatically will be secreted less because TRH is also secreted less. So there is always a negative feedback is always there, isn't it? So that's how it will always be there. So if there is a destruction of the hypothalamus or pituitary, anterior pituitary, so then the patients will develop secondary hypothyroidism. So what is the cause for this destruction? Common cause. What is the syndrome associated with that?
Sheehan's, sir.
Sheehan syndrome. Sheehan syndrome or pituitary apoplexy, isn't it? Especially in pregnant women when they deliver because of the severe
Blood loss.
bleeding, blood loss, they can have severe ischemia of the hypothalamus and pituitary and they may get destroyed. So that is called as the Sheehan syndrome. Usually patients will develop secondary hypothyroidism. So now my question was, how do you classify primary hypothyroidism based on TSH values?
Clinical and subclinical hypothyroidism. As in,
Very good.
with subclinical hypothyroidism, the patient will not have any symptoms nor signs, but on seeing the TFTs, we will see that the TSH is on the higher side and T3, T4 will be normal, sir.
How much higher side? See, anything above 4.5 is high, isn't it?
Yes, sir.
As Dr. Hema was talking about, up to 4.5 is normal.
Yes.
Anything about 4.5 is high. It is very, very sensitive, TSH.
Yes.
If high means there is definitely hypothyroidism is there. Even upper normal limit, you can think there may be hypothyroidism. So anything above 4.5 up to 10, with T3, T4 being normal, it is subclinical.
Okay.
10 to 20 is, mild hypothyroidism, where marginally decreased T3, T4 will be there with higher TSH being 10 to 20. 20 to 50 is, moderate hypothyroidism. Subclinical, mild, moderate, and anything above 50, it can even go to 150, 200 also in severe. So anything above 50 TSH, you can say severe hypothyroidism based on TSH values. Sometimes you may be asked. Okay, so one more investigation, even in Miller it is given, and you may be asked, what is this THBR, thyroid hormone binding ratio, and thyroid estimates? And what is the old name for THBR, thyroid hormone binding ratio? Very common, this question is very fond of being asked by many of the examiners.
Ratio of total to free.
No. No, if you know, you just say, otherwise, need not have to guess, because anyway, there's a discussion part on it.
Yes.
What about Hema? Any idea about THBR, thyroid hormone binding ratio? What was the older name?
No, sir.
You may be knowing T3 resin uptake test. Have you heard about T3 resin uptake test? You're not heard about. So this is the older name was T3 resin. Radio labeled T3 resin uptake test was the older name. Now the present name, it is called as thyroid hormone binding ratio. It is there in Miller. If you just see concurrent diseases and anesthesia, regarding the thyroid diseases and anesthesia, in that chapter, Miller has in detail, he has explained this. And what is this thyroid hormone binding ratio or T3 resin uptake test is? It's an in vitro test. You take the blood of the patient, and for this blood, one has to add radio labeled T3. Radio labeled T3 is added, and then resin is added later. After about 5 or 10 minutes, resin is added. And this resin can bind to radio labeled T3, which is free. Because what happens once you add T3, radio-labeled T3 into the blood will have thyroid binding globulin. That is a protein. So radio-labeled T3 will go and then, combine with the TBG, isn't it? If the sites on the TBG is already saturated, then more amount of radio-labeled T3 will be freely available for resin to be uptaken, isn't it? Resin can take up, or radio-labeled T3 will combine with more resin. So then uptake is high, isn't it? So when you can have radio-labeled T3 resin uptake test being high, when you can have, there can be reduced or number of sites available on TBG. So what happens, I'll just explain about this particular test because it is commonly asked. Many times when you get a T4 done, they'll not give you actual T4. It's actually the T4 which is combined with TBG. That is the value. Actually, you'll be getting the value of TBG when you are getting a total T4 investigation done. So that means suppose in certain conditions where TBG is very high, then you also get T4 to be very high. And the conditions where TBG can be high is in pregnancy, TBG can be high. In patients who are on, or in women who are taking these oral contraceptive pills, it can be high. And also in case of some hepatitis, it can be high. So wherever there is increased amount of estrogen release, estrogen is present, so TBG will be high. So once the TBG is high and you are getting a high T4 levels when you do the investigation, you don't know whether this T4 level high is because patient having hyperthyroidism or because increased levels of, you're following, I hope. Isn't it? So suppose if level of TBG levels are high, but thyroxine levels are normal, the patient is not having hyperthyroidism. So T4 levels are normal, but you are getting a spuriously high report because TBG levels are high. Now, when you add radio-labeled T3, there will be a lot of sites vacant on the TBG because the TBG level is high, isn't it? So more amount of radio-labeled T3 will combine with TBG now. And free TBG levels will be very low for resin to combine. So what happens to the uptake of resin by the radio-labeled T3? Will be less, decreased, isn't it? So if radio-labeled T3 resin uptake is less, this is called as thyroid hormone binding ratio. If the thyroid hormone binding ratio is less, but T4 values are high, then it is because of the increased TBG levels and not because of hyperthyroidism.
Yes, sir.
That is what is called as THBR. Suppose the opposite occurs. Suppose if, in a hyperthyroid patient, T4 levels are high, TBG levels are normal. So all the sites on the TBG are now already occupied by T4 because T4 levels are very high, TBG levels are normal. Now, when you add radio-labeled T3, there is hardly any sites for the radio-labeled T3 to occupy on the TBG. So there will be a lot of free T3 will be available for resin to be taken up. So resin uptake will be very high. So in real hyperthyroidism, the resin uptake will be radio-labeled T3 resin uptake will be high. Not THBR, what we call nowadays, it is high. Whereas in case of TBG levels are high, T4 levels are normal. Seriously, you are getting a high T4 levels, then radio-labeled uptake will be normal. Sorry, will be decreased. Normal ratio THBR is about 31% to 35%. THBR. Just remember about this T3 resin uptake and THBR. You can just read it in Miller today only. It is there in the concurrent diseases and anesthesia chapter. So you can be asked in the exam about this THBR. So when you multiply by this THBR value with the total thyroxine, you get what is called as thyroid estimate or thyroxine estimate or free thyroxine estimate. This is total thyroxine multiplied by THBR. So that is again, it will be very high in hyperthyroid patients. It may be low or normal in case of TBG levels are high and in hypothyroidism. So probably you may not be following what I'm telling. It may be confusing for you because every time, whenever I talk about this, students will not understand initially. Then I'll have to write down on the board, blackboard, and then I'll have to discuss, and then I'll have to ask them giving examples, then only. But today only you go and read in Miller about THBR, thyroid hormone binding ratio. Not only you, for all the students.
Yes, sir.
They can, then definitely you will understand what is this T3 resin uptake test. Otherwise, now it is called as radio label THBR, thyroid hormone binding ratio.
Okay.
Okay, what are the other investigations? We'll just finish today investigations. We'll continue anesthesia part next week. What other investigations you will be doing for this patient other than this?
I'll be asking for indirect ideal, sir. So in view of vocal cord palsy, to rule out any vocal cord palsy, sir.
Okay, you can even do a indirect video laryngoscope.
Yes.
Nasoendoscope, now it is called as, and many of the ENT people will be doing nasoendoscope. So you can even take the video of the movement of the vocal cords preoperatively, isn't it? So it becomes very important. Why this is important? One is medico-legal, because during surgery there can be damage to the recurrent laryngeal nerve, and the if you have, or it may be already there because of the pressure effect, and the patient may claim it is because of surgery. So once you have a video recording of that, so there won't be any problem at all. So the second thing is for us, as I was telling you, because awake intubation, so you may have to take a smaller tube. So if you paralyze the patient, there won't be any problem. But if you are going in for awake intubation, then you have to go for a smaller tube. Okay. Other than these, any thing for the gland itself, any investigations?
For FNAC, I will ask first to rule out any.
Before that, thyroid scans are done using I-123.
I-130.
The iodine 123. 131 is used for radiotherapy.
Yes.
So radioactive iodine therapy. So I-123 is used to see uptake, radioactive iodine uptake test. So again, scans are taken. You have warm nodule, hot nodule, and cold nodules. Warm nodules are normal. Hot nodules, hyperthyroidism. And cold nodules is a malignancy. They'll not take up. So this is thyroid scans can be done. Okay. What else? X-ray neck.
X-ray neck,
AP
lateral.
Yeah, to know whether there is any deviation of the trachea, and also to know whether there is compression. Anteroposterior will give us lateral deviation, and lateral view will give anteroposterior compression. So you get a lateral and the AP. Then you don't unnecessarily expose the patient for this unless the thyroid, the tumor is very large. A small thyroid, don't ask for a X-ray because there will be hardly any deviation or compression. Okay, so that is another very important thing. And if you think that you are not getting under the gland, and probably the Pemberton sign may be positive, and if you are thinking that there may be a retrosternal extension, then definitely you will ask for a CT scan or MRI. MRI CT becomes important. Then one more thing is you can also go for an ultrasound of the gland to know whether solid tissue or cystic.
Yes.
It's very easy. And also you can probably you can even know retrosternal extension by using the ultrasound scan. So these are some of the investigations you'll be asking for. Okay, so we will stop at this. So next week, we will just finish off the management of the anesthesia part and also the complications that occur. And before that, you'll have to start with the preparation. You can make yourself, or prepare yourself. One is how to prepare these patients. And invariably, you may go for general anesthesia, or it can also be done under regional anesthesia, thyroid surgeries, because it's a superficial surgery. So what are the indications for regional anesthesia, how it is done, and how you plan for your general anesthesia? What are the problems? What are the intraoperative complications of general anesthesia? How do you extubate, and what are the problems immediately after extubation, and how you manage these complications? And then again, a few things about thyroid crisis we'll have to discuss, and also management of hypothyroid patients.
Okay.
For anesthesia, when they come for, majority of the times they come for the non-thyroid surgeries. Any other non-thyroid surgeries, hypothyroid patients, you must have given anesthesia for these patients. So when they come, how we are going to manage, and also myxedema coma management. Again, it is a short notes. Many times it will be asked. Again, in the exam, you can be asked. So these are the things we will discuss the first, 1 hour the next week. And
Okay.
afterwards, we can go for the next long case. I think pulmonary COPD, I think next week planned. Mukhtyar will be knowing about it.
Yes, sir. Next week it's COPD, sir.
COPD. So before
Yes, sir.
COPD, we'll just finish about 1.5 hours, maybe, about management of anesthesia part, which is again very important. Now, everything is important as far as thyroid is concerned. What we discussed till now, and again, the anesthesia part, how you are going to manage. So we'll go into details about that. Anyway, thank you so much. You people are answering very well. I'm very happy with the students of MGM. So
Thank you, sir.
we'll continue next week. And
Yes, sir.
Mukhtar, last week's this thing has been added to the video, has been added?
Yes, sir.
It has been added, is it?
Yes,
Okay.
sir.
No,
Now,
I just,
yesterday's video I'll be adding today to the drive, sir.
okay. Now, I just wanted to ask you, you said that it will be available in YouTube also.
Yes, sir. So mitral stenosis part 1 and part 2, we have already added to YouTube, sir. So
Oh.
YouTube channel is Academics MGMCRI.
Academics in GMCRI.
MGMCRI, sir.
MGMCRI. Okay.
MGMCRI. So
Okay,
2
that-
videos we have already uploaded to YouTube as well.
Okay, right. Thank you. We'll meet again next week, both Hema and Krishna.
Yes, sir.
Right, appa. Good night.
Yes, sir.
Thank you, sir.
Thank you, sir.
Yeah. And any doubts? Today's this thing, we can discuss first in the
Yes.
next. Okay.
Sure,
Right.
sir.
Okay. Bye.
Thank you, sir.
Right.
Thank you, sir.